Good morning, kids. Today, you are going to learn a little bit about how to see an MRI and a CT, like the normal structures of the brain. And also, you'll be learning a bit about diagnosing herniations, specifically your cingulate gyrus herniation, that is subfalcine herniation, and the transtentorial herniation, which will have a greater emphasis. So, without further ado, I'm going to share my screen. Okay, so this is the video of a patient with a temporal lobe, a right side temporal lobe, this tumor. And in this case, there is a bit of herniation of the temporal lobe and which is crushing the brainstem. Although the patient is completely fine, frankly speaking, herniations are only dangerous when they happen acutely, as in the case of traumatic brain injury, because the compensation mechanisms are not yet active. But in the case of slow-growing tumors or even fast-growing tumors, the effects of herniation are much more muted, and the patient usually comes to the hospital before any dangerous signs come up. Okay, so although it will look bad, the patient with a tumor will not be as decompensated as a traumatic brain injury with the same amount of herniation. Okay, so let's just get on with it. So whenever you see a normal CT scan, okay, always try to go from bottom till up rather than from up to down, okay, because a lot of the structures which are useful to you are more on the bottom side than on the upper part of the brain, okay. So initially when you start, usually these CT scans are taken. There are a few things that you need to know about the CT scan. When these CT scans are taken, they ideally should be taken with the patient's head straight. And although they take the CT scan of the entire skull, they take it in slices, right? And the slices need to have a specific angle so that you are able to make sense of what is going on. Okay. So the convention is to take the slices parallel to the skull base. Okay, like this basically. They are supposed to be taken like this. But sometimes the radiologists radiology technicians, when they are in a hurry or pressed for time, they do not correct for that and they take slices parallel to the ground. Okay, so you need to know how the slice was cut before you diagnose anything, because a lot of the morphology it looks different when you are seeing it at a different slice angle. Okay, so this one luckily has been taken at a correct slice angle, that is, it's parallel to the skull base. Okay, so mostly they will start at the bottom of the skull. And what is there at the bottom of the skull? Below the foramen magnum, right below the foramen magnum is the C1 vertebra. Okay, so this is basically your C1 vertebra. Okay, and in the foramen transverse area, you are able to see the two vertebral arteries. Right, now let's just continue. Okay, this is just a video of one of the patients, and I'll be going through the video and explaining things in different stages. Okay, so as soon as you go slightly above, okay, you are basically approaching the foramen magnum from below. You are able to see the CSF, and this is the spinal cord. Okay, this is like right below the medulla. You know that the brainstem consists of midbrain, pons, medulla, and then it continues down as the spinal cord. Okay, so when it exits the skull, that's basically when it is spinal cord. So right now it is the spinal cord here, and around that you can see the CSF space. Okay, let's just continue. Okay, now you are able to see this is basically your foramen magnum now, because you are able to see the posterior part of the skull. Okay, remember in a CT scan image, your bone will be densely white. Air, which is around the patient basically, air will be densely black. Okay, and water will be somewhere in between, which will be blackish. Okay, anything which impedes the X-rays. Okay, like tissues, anything basically which is harder. Anything which is harder than water will appear more whiter. Okay. So right now, since you are seeing the foramen magnum and the posterior part of the skull, this is basically the posterior part of foramen magnum, part of the occipital bone. Okay. So just above this, you'll be able to see the cerebellum, and right now you are looking at the medulla. Now the resolution of a CT scan is much worse than that of the MRI. So making any diagnosis regarding the posterior fossa is not really possible using a CT scan. That is also because when the X-rays pass through a hard structure, okay, they have problems when a hard structure is interfaced with a soft structure. Okay, it can cause artifacts to develop in the image. Okay, so those artifacts are known as bone hardening artifacts. And since the occipital part of the skull, which surrounds the posterior fossa, is a thick bone, the posterior fossa is not very nicely seen in a CT scan. For posterior fossa diagnosis, always go for MRIs. Okay, so let's just continue. Okay, so here you are able to see the dents. This is the C2 body of the C2 vertebra, and you are able to see the C1 vertebra. Let's continue up. Okay, now you have officially reached the foramen magnum. You are able to see the cerebellum here. Okay, so if you have seen an MRI in the past, you would know that the cerebellum appears as a striated structure. But in this case, it's not appearing striated, mainly because you are not able to, the resolution is not very good. Okay. Along with that, sometimes you will see artifacts, okay, which are like white beams coming out of the skull. These are known as bone hardening artifacts, and these are a normal thing. You cannot do anything about it. Okay. And now you are officially seeing the medulla. Let's go up. Okay. So here you are able to see the cerebellum, the medulla, and these are the two vertebral arteries which have come up through the cervical foramen transverse area, cervical vertebra foramen transverse area, and then they loop forwards. Basically, they bend forwards at the foramen magnum, like over the arch of the C1 vertebra, and then they meet together in the front to form the basilar artery. Okay, so they will meet and form the basilar artery. The basilar artery will go in front of the pons and in front of the midbrain, and there it will divide into two PCAs, which will loop around the midbrain. Okay, so let's just look at that first. You are able to see the two vertebral arteries, and they are now coalescing to form the basilar artery. Okay. Now, next important thing, when do you know that you are at the pons level? When do you know when you are at the medulla level? Okay. So let's just go a little back. Okay. So here you can see that just a little back more. So here you are able to see that the brainstem, the part of the brainstem is very well delineated compared to the surrounding cerebellum. Okay. Now, what happens is that as you reach the pons have got dense pontocerebellar connections, okay, to the back. So when you see the brainstem and the cerebellum merged, that basically means you have reached the pons. Okay. And along with that, you will see a diamond shaped structure here, diamond or a circular or a squarish shaped structure here. That is basically your fourth ventricle, because the fourth ventricle, the bed of the fourth ventricle is on the pons, and it forms a tent like thing over the basically it is like a tent in the going into the cerebellum. If you look at it from the sagittal view, if you look at it from the axial view, it will appear as a squarish or a roundish type of shape. Okay. Let's go. Okay, so now you're able to see how the pons is, now we have reached the pons because it is merging with the cerebellum. Okay, and here this is the fourth ventricle. And here you are able to see the two vertebral arteries about to join to form the basilar artery. Okay, now it has formed the basilar artery. You are directly on the pons, you are able to see the fourth ventricle. Now let's go up. Okay. Now, are you able to appreciate the change in the shape? The shape of the midbrain is basically like a heart. When you look at it in the axial view, it looks like a heart. Okay. And this is where you will be able to see the bifurcation of the basilar artery. Okay. So you're able to see some arteries coming out of the basilar, and very soon the basilar is gone. Okay. That is because it has split up. Now, the problem with CT scans is that it has got very big slices. Okay, like basically each slice is 5 millimeters thick. So because of that, finer details will be lost. You'll be able to see this thing much better in an MRI. Okay. Now let's go for looking at the posterior fossa related stuff, specifically your herniations. Okay, the transtentorial herniation. Okay. Now, before we go for the herniation discussion, we have to know a little bit more about the anatomy of the posterior fossa, brainstem, and the temporal lobes. Okay, so these structures that you see, okay, this line that you are seeing, this is basically a cut section through the tentoria, the tentorium cerebellus. Okay, the tentorium cerebelli is basically a basically looks like this. Okay, this is the posterior part, the skull. Okay, it has got two flaps, sort of flaps, which are joined outside on the skull, and it has a split in the middle. The anterior part is attached to the petrous part of the temporal bone. Okay, and in between this hole, the brainstem goes down. Okay, so it is basically like this. On top of the tentorium, there is the temporal lobes. Okay, so knowing this anatomy, you'll be able to make out this is the tentorium. Okay, these are the temporal lobes. This is the midbrain, and just behind the midbrain, what is there behind the midbrain? Cerebellum. Okay, so you are basically able to see the cerebellum just below the tentorium, and it is seen like this because the cut is taken at an angle which is parallel to the skull base. Okay, now the skull base is angled upwards and the tentorium are angled slightly downwards. So when the cut is taken, it will capture a little bit of the cerebellum, a little bit of the tentoria, a little bit of the temporal lobes, and actually the whole of the temporal lobes and the brainstem also in that cut. Okay, so this is how it typically looks. Okay. Now, around the brainstem, you are able to see some black stuff. Okay, this black stuff is basically your cisterns. There's a CSF which surrounds the brainstem. Okay, now what is a cistern? Cistern is, the technical definition is that it is a CSF pocket inside the skull. Okay, now the thing is that there's nothing called a CSF pocket inside the skull apart from ventricles, which are actually pockets of CSF. Okay, apart from that, the brain is just floating around in the CSF. Okay, now when you take cut sections, it will appear like because there are many indentations inside the brain, and everywhere CSF is filled up. Okay, so when you take a cut section, it will appear like those CSF filled areas have a defined shape. Okay, actually there is no shape. Okay, but based on that look on the CT scan or an MRI, we define them as specific cisterns based on their location. Okay, so the cisterns, that is the CSF spaces around the brainstem, are known as, specifically around the midbrain, are known as perimesencephalic cisterns. Okay, or the ambient cisterns. The perimesencephalic, mesencephalon is the midbrain. So surrounding that, perimesencephalic cistern. That's all. Okay. Now, these cisterns are basically a differentiation, pictorially, they are a differentiation between the brainstem and the temporal lobe. The texture of the two is also different. Okay, so let's go ahead and see. Okay, so here you are able to see that these cisterns, like this is the midbrain. Okay, but you are able to see that the cisterns are basically gone. Okay, there is no cistern here. That is because the CSF has been displaced because of mechanical movement of the temporal lobe crushing the brainstem. Okay. Now, where do you look for tentorial herniation? Let's first see what a tentorial herniation is. Now, you remember this image in your mind that this is the tentorium, the temporal lobe is at the top, brainstem is in the middle of the cut. Okay. Now, when the pressure in the temporal lobe increases or the temporal lobe swells up, it has nowhere to go. What it does is it pushes the tentorium down like a curtain and it slips down. Okay. As soon as it slips down beyond the edge of the tentorium, it crushes the brainstem, which is right there. Okay. And whatever structures are in between the tentorium and the brainstem, they also get crushed. The prominent of them is the PCA, the posterior cerebellar artery, which is an offshoot of the basilar artery going around the midbrain. Remember that? So that basically also gets crushed. Okay. Now this is exactly what you're seeing here. Okay, you can see that this is the temporal lobe, this is the brainstem, and this is actually the PCA, which is getting squeezed a little bit. Okay. Luckily, this is a slow growing tumor, and the crushing of the PCA has not happened. But when it is a TBI case, then it will definitely happen. Okay, so because of that, PCA infarcts are pretty common when a patient has herniated transtentorially. Okay, now where to see the transtentorial herniation, at which cut? I'll define this for you. So this in front of the brainstem, this part, this bony thing is known as the clivus. Okay, this is the posterior edge of the sella turcica inside which the pituitary sits. Okay, now this clivus, you allow the clivus to come, and after that, you go, so after the clivus has come, you go a little bit up. Oh, sorry. Where did I go? So after the clivus has come, you go one step above the clivus. Okay, as soon as you go one step above the clivus, you will classically see the midbrain, okay, and the temporal lobe, and you should be able to see the cistern around it. Okay, so here you are not able to see anything like that. Okay, you are able to make out the shape of the temporal lobe, and by that you are able to know that this is the brainstem. Okay, and you are able to see the temporal lobe outline here separately. Okay, so this specific feature is known as uncal prominence. Okay, so there are certain grades to it, to the transtentorial herniation. It's not defined in textbooks or articles, but I have made up my own grading to get an idea of this. Okay, so what happens is initially when the temporal lobe will swell up, it will displace the CSF. Okay, at that time, you are able to see the brainstem separately and the temporal lobe separately with a thin layer of CSF. That is relatively safe. Okay. After that, you are able to, in the next grade, you are able to see that the temporal lobe has swollen up a little bit more, and your CSF has been completely displaced, and your brainstem is getting a little bit squeezed. Okay. Now, when that happens, that is known as uncal prominence, like in this case. Okay. But still, even though the two structures are abutting each other, you are able to make out the difference between the texture of the two structures. Okay. The texture difference is important because that basically means that damage has not yet set in, edema has not yet come. If edema is there, then then both of them will become sort of homogeneous in their texture. Okay. The next stage, when the herniation has actually happened and the damage has happened, that basically means that your edema has set in and you are not able to make out the differentiation between the temporal lobe and the brainstem. Okay, so that sort of case happens when it is a badly herniated case. In this case, you are able to see the uncus, that is the medial part of the temporal lobe, squeezing the midbrain. Okay, this I think is much better visible in the previous cut. You are able to see this. So this is the temporal lobe and this is the midbrain. Okay. Mostly you'll be able to see this sort of image in a cut above the clivus. Okay. In this, somehow it is coming at the level of the clivus, but you will usually see it one cut above the clivus. Okay. So this is how you diagnose transtentorial herniation. Now let's go a little more up. There are a lot of things to understand about the normal anatomy, but right now we'll just focus on the herniations. Okay. Now, next, let's look at the upper part of the brain. Okay. I'll just let it play out until we get to the top. Okay. So when you get to the top, you are able to see that there is a line in the middle. Okay, this line in the middle is basically your falx cerebris. Okay, falx cerebris is basically a structure which goes over the brain. Basically, it goes between the cerebral hemispheres, but above the corpus callosum. Okay, and it is like a band of tissue which is in between the two cerebral hemispheres. Okay, now this band of tissue is Below this, right, there will be the corpus callosum, and below that there will be the third ventricle. On the sides, there will be the lateral ventricles. Okay. Now, if the pressure increases in the parietal lobe or superior temporal lobe, okay, superior part of temporal lobe and the or the parietal or the posterior frontal area, okay, then what will happen is that the cerebral hemisphere will swell up. When the cerebral hemisphere swells up, it will start pushing to the other side of the brain, which is normal. Okay. So when that pushing happens, what will happen is this third ventricle, which was there in between, that will get pushed to the other side, slightly pushed to the other side. Okay. If it is a more superior, the edema is happening in the little more superior part of the parietal or posterior frontal lobe, then you will be able to see the forks also bend. Okay. Now the forks bending doesn't really happen like you won't be able to see it like a bent forks. Okay. What you will be able to see is in this, in the cut, anterior and posterior part of the forks is visible. In between, it is gone. Okay. That is because it has been pushed up like a curtain. It has been pushed up like a curtain, and now it is not visible in this cut. Okay. You understand? It's like a cut, right, through the forks. So anterior, posterior, in between, it has been pushed up like a curtain, and the brain is going to the other side. Okay. So this is your subfalcine herniation. Okay. So mostly the midline shift that you see is a form of subfalcine herniation. Technically, subfalcine herniation only happens when it is more in the upper parts of the cortex. Okay. Upper parts of the cortex pushing the forks and going below it to the other side. Okay. But the damage which happens because of that is similar in midline shift, similar in that also. Okay. It's almost similar. So because of that, it is defined as, defined like that. Okay. Now let's just go a little back so that we are able to see the pushing. Okay. So let's just see if we can identify the. Okay, in this, you will not be able to see the lateral ventricle of the other side at all because it is completely squeezed. Because it's a slow-growing tumor, the lateral ventricle has been completely obliterated. In traumatic brain injury cases also, it might be completely obliterated, but usually you'll be able to see a thin strip of CSF of the same side. Okay. Now, where is the third ventricle? You have got the two lateral ventricles on the side. Okay, they have got an anterior horn going into the frontal lobe, a posterior horn going into the occipital cortex, and they have got two branches basically which come out and go into the temporal lobe. So the shape is like this, going back and then coming to the front. Okay, this is what a ventricle looks like. Okay, now in between the medial parts of the ventricle, they are joined to form the third ventricle, and this hole is known as the foramen of Monro. Okay. Now this third ventricle will appear when you take a cut section of it. It will appear as a slit. Okay. Above that, it will appear as a slight bigger hole. If the CSF is more, like there is a bit of hydrocephalus, then you'll be able to see as a hole. Okay. And then you'll see the lateral ventricles. Okay. Below that, below the third ventricle, it continues as the aqueduct of Sylvius. The aqueduct of Sylvius is nothing but CSF space above the brainstem. It basically goes over the roof of the brainstem, along the roof of the brainstem to the posterior part of the brainstem, and then behind the pons, it forms the fourth ventricle. Okay, in a sagittal view, you'll be able to see this going above the fourth ventricle very easily, above the brainstem very easily. In this, it will appear as a dot which goes from the front, a black dot which goes from the front of the brainstem to the back of the brainstem. But in a CT scan, because the cuts are too thick, you won't be able to see the front black dot mostly. You'll just see it as a black dot at the posterior part of the midbrain. Okay. So we are getting a little off track here, but this is what a midline shift looks like. Okay, basically the middle part of the inferior part of the parietal lobe, posterior frontal lobe, and or the superior part of temporal lobe, they get swollen up, they push, and they push the third ventricle to the other side, and the lateral ventricle of the same side also to the other side. The lateral ventricle of the same side will be squeezed. Okay. Now, there are specific definitions as to where to see the midline shift. Ideally, it should be seen at the level of foramen of Monro. Okay. But as I said, foramen of Monro is in normal circumstances not very well visible. It is well visible when it is in the hydrocephalus is there. In these sort of cases, when it is squeezed, it is likely not to be seen. The third ventricle itself is much more difficult to define. So mostly what people do is definition of midline shift happens with the septum pellucidum. Septum pellucidum is basically the septum between the two lateral ventricles. Okay, the septum pellucidum is between the two ventricles. Below that, there is the whole of foramen Monro. So just above that, the septum pellucidum, that's what is used. The differentiating point between the two lateral ventricles is used to define the midline shift. Okay. So so basically here, this is likely the septum pellucidum, although you can't say for sure because the other side ventricle has been completely squeezed, has been completely obliterated. Okay. Actually, here you are able to see much better. I'm having to do this on a video because otherwise there is identifying information about the patient on the e-hospital portal, like in the PACS portal, basically. So, okay, so this is the septum pellucidum. This is the lateral ventricle of the same side, and you can see how much it has been obliterated. Okay, so now how do you calculate the midline shift? Okay, you will see the surgeons do it in a specific way. Some of your seniors will also do it in this way, but this is the wrong way. I'll show you the wrong way and then I'll show you the right way. So in the wrong way, what people do is they take the midline from here, the nasion to the inion. They will draw a straight line like this. And then from that straight line, they will draw a 90-degree onto the septum pellucidum, and they will take this distance as the midline shift. Okay. Now, there is a problem with this method. The problem is that most of the traumatic brain injury cases are a bit irritable. Okay. And because the CT scan has to be done urgently, the patient's head may not be completely in the middle, like straight in the middle when they are taking the CT scan. It can be bent to this side or to that side. Okay. So in those cases, what you should be doing, and in other cases also, what you should be doing is you identify the level at which you are at which you want to take the midline shift. Okay, suppose the middle of the septum pellucidum here. Okay, after that, what you do is you draw one line in that at that level from one table of the skull, one side table of the skull to the other side table of the skull like this. Okay, and after that, you draw one more line from parallel to that line from the table of the skull to the septum pellucidum. Okay. Then the first line, you take half of it and subtract it from the second line. Okay. That will tell you the midline shift. Okay. So basically the distance from one side of the skull to the other side of the skull, half of that is where the midline should be. Okay. And the new midline, which is defined by taking from the skull table to the septum pellucidum. Okay, so this new midline minus the correct midline, that is your midline shift. This is the method which is basically published by the Brain Trauma Foundation guidelines. There is a Brain Trauma Foundation guidelines for surgeons also, neurosurgeons also. So this is published there. Okay, so you should be answering this in your viva, as well as try to use this when you are doing your cases, or basically when you're doing your trauma cases. Okay, please do not use the midline and from there. Okay, now if the patient's head is completely in the middle, like in this case, you will get a correct answer from that. Okay, but if the patient's head is tilted slightly, then you will not get a correct answer. At that time, please use this method. Okay. So I guess this covers whatever I wanted to teach in this video. You learned a little bit about the anatomy of the posterior fossa, a little bit about anatomy of the ventricles, a little bit about transtentorial herniation, and a little bit about subfalcine herniation. Okay. So please read about this when you are able to, and have a good day.